So I'm live at the Greater New York meeting, and I was just talking to a friend of mine, and Alan Miller of Alan Miller Design Lasers, and he said you were, when he launched his laser, you were the smartest guy he could find to teach lasers. So congratulations on being that guy. I mean, there's 2 million dentists on Earth. Why did he pick you to teach lasers? What's your background in lasers?
Well, so I've been practicing 25 years. Day one, started using dental lasers. I've taught for every laser manufacturer. According to him, I've trained more hard tissue and soft tissue laser owners than anybody around. Might be a little bit of an exaggeration, but I'm probably up there of top 3 guys who've trained more laser owners than anybody on hard and soft tissue lasers. So I know a little bit about lasers.
So did you start off in soft and move to hard, or hard to soft? Or
so here's a great story.
Yeah,
so
tell us your very beginning. So where'd you get out of school?
Went to dental school at Buffalo. When I was in school at Buffalo, sophomore year.
Please tell me you're not a Buffalo Bills fan.
I am not a Bills fan.
Otherwise, your heart may be going out on you right now. We may need to call a cardiologist.
Definitely not a Bills fan. So when I was in dental school at Buffalo, sophomore technique crown and bridge was a critical class, and if you flunked crown and bridge, you had to repeat a whole year. Well, there was an instructor who him and I didn't get along, and obviously, in that respect, student loses. I flunked sophomore technique crown and bridge by 3 points out of 400. He made sure to grade my last 3 practicals, and I flunked. I got A's and B's and everything else. So I petitioned the school. They wanted me to repeat the entire sophomore year. I petitioned the school, and they said, all right, just repeat some of the technique. You can move on didactically. That left me with a ton of free time because the schedules didn't totally mesh. A instructor in the oral surgery department who recently passed away, Chuck Lebo, said to me, Ron, why don't you come do some laser research when you have all this time? And I said, laser research, what do you know about? I don't know anything about lasers. I'll teach you. So fast forward 2 years later, so I did dental school in 5 years, but fast forward 2 years later, I was the university's representative at the ADA meeting back then in Hawaii, showing my laser research. I presented at a medical meeting, the Academy of Laser Surgery and Medicine, my medical research in front of 300 physicians, my first lecture in my career, and got out to private practice and had to have a laser. So the guy that flunked me in crown and bridge basically changed my course of my career because I had lasers day one, became a key opinion leader way back when with a variety of manufacturers because of my lasers, and he wrote my destiny.
That is so cool. Turn lemons into lemonade. So what was your first laser?
First one in my office was a Luxar carbon dioxide laser, soft tissue laser. That was my training originally. Very quickly, a number of years later, I walked past the BioLase booth at the Academy of Cosmetic Dentistry meeting, started playing with a hard tissue laser. Maybe they had sold 40 or 50 in the country. And as they were closing the booth, after I visited back about 10 times, the booth was being taken down kind of like around the time now. And the rep said to me, he knew me by name already. He said, Ron, you going to buy this thing or what? And I finally said, all right, let's do it. Back then, there was no training. The reps didn't even know much about it. I started developing techniques and courses and went to BioLase and said, hey, you can't sell these things without a training course. So we started training dentists. I have a facility that we built in New York, a training facility. Did that for BioLase for a great number of years, then for Fotona. And now AMD's launching their hard tissue in the States, and we're going to start training. We're going to have 3 centers across the country, one in New York, one in Chicago, one in Colton, California. We're going to start training our hard tissue laser owners as well.
Okay, now where are those training facilities? What are they dental offices?
They are dental offices that have a separate facility, whether it be a dedicated area where you can, with plasma TVs connected to computers, areas where not in the clinical space. My office, for instance, we have a finished 2,500 square foot basement facility that has TVs wired up to the operatory with sound, so I can totally be doing work on a patient, have someone down there who's with me, communicate questions and things like that. And they can watch a procedure, eating a New York bagel downstairs while I'm doing a procedure.
So where are your 3 centers going to be?
One in New York.
Is that New York? Is that your office?
That's my office.
And how many does that hold?
It'll hold 35 people.
And how many operatories?
My operatory has 6 operatories in the facility.
Okay. And then what's the other one?
The one proposed is going to be in Chicago. I haven't seen it recently, but when I've been there in the past, held about 20 people, also a 7-operatory office. And
who owns that office?
Frank Feng is the dentist who potentially is going to be teaching, and James Jesse in Southern California in Colton.
Oh my God!
Do you know James?
He's an instructor at Loma Linda.
He is, absolutely. And Jim and I taught hard tissue lasers together for 15 years. He'd come to New York.
I took his classes 20 years ago.
There you go.
Yeah, he's an amazing guy. And there's also a facility. Implants Direct has a facility
Correct.
in Vegas.
So we're going to look for other opportunities, I think, as well. It depends, I think, on volume and how many people we're going to train.
Can you leave a message to James Jesse that
Absolutely.
I want to podcast him?
Done.
I'll
text him when we're done.
He's so damn cool.
Jim's a great guy.
So he's going to be one of your instructors?
He definitely will.
So who all your instructors going to be?
Right now, we're putting together our body of instructors. We're going to seek out a good number of people who we know have taught in the past. Lasers are about training. Dentist who's happy needs to be trained well. Jim's a phenomenal educator, as you say. Jim and I taught for many, many years. So we're really going to go after some experienced guys who've been in the industry for a while.
So you used to work for BioLace for a long time.
So I wouldn't say work for them, but I was one of their key guys way back when.
So I guess the most uncomfortable question I could ask you, since this is, Dentistry Uncensored with Howard Farran, what's the difference between this and BioLace? Because this is Light Touch is an erbium YAG for about $50,000.
Correct.
What's a BioLace cost?
So the BioLace probably runs between $70,000 to $85,000. They're similar family of wavelengths. BioLace is a patented wavelength, but they're very, very close. They're both erbium family wavelengths. They both cut hard tissue and soft tissue really, really, really well. There's nothing bad to say about BioLace. Al Miller is brilliant when it comes to bringing quality into the market at lower cost. This unit is much smaller, more compact, carries the same power, is able to do exactly the same things for really almost half the cost. It's going to be a fun ride.
Well, does it have to go? Because this is 50, and you said the other one's 70 to 85?
Two-thirds of the cost.
So a third less.
And the other, let's say you want to call it the other hard tissue on the market, Solea, which is a CO2 hard tissue, but still a hard tissue laser, is up $119,000. So those are when people are looking for lasers, they're going to look at Solea, BioLaser, and Photonon.
So talk specifics. What is really the difference between a carbon dioxide, a CO2 hard laser, and an erbium?
It's all on the wavelength. They're all vaporizing water within the tissue itself. It's all on the wavelength. Talk to the Solea guys. They'll say theirs is more efficient and quicker. I think it's about they all cut hard tissue really, really well. If you closed your eyes and I gave you each laser and you looked at what you had afterwards, you'll see a nice preparation probably with all of them. They're all extremely, extremely efficient. What Al did for the diode market, AMD, when diodes was selling for $10,000, $12,000, he brought the Picasso in and sold it for $5,000. He went from what I call zero to hero in 5 years. He #1 selling soft tissue laser in the world in 5 years. And he's poised to do the same with this. Dentists are still always price conscious, but give them something of value at the right cost, teach them how to use it, get the best trainers out there, support it with the right manufacturer, and it's supposed to be a winner, and that's the direction that he's really heading into.
So, talk to my homies out there. The number one thing we hear from patients is, it's just half the questions are money, money, money. How much is it? Will my insurance pay? Will Care Credit finance it? Can I make payments? So half the issues is money. But after money, I say it switches to pain. Do I have to get a shot? Do you have nitrous oxide? Can you put me to sleep? Then it probably moves to, what is it going to look like? What teeth is it? So sometimes we hear from lasers that you don't need a shot. Another dentist saying, they're full of it. That's marketing. Tell the truth. If someone bought a Picasso, a Light Touch, erbium YAG, hard tissue laser, what fillings could it do really without a shot?
So one of the things I think that many manufacturers have built on and years ago was no shot, no pain dentistry. And the reality is you can do a lot without anesthetic, but to say that I'm not giving an injection ever again with any of these products is absolutely false. Having done 20,000 teeth over the years, probably with lasers, I would say I can do my pediatric dentistry 90 to 95% no injections. That's routinely, regardless of depth.
Pediatric dentistry, what? 90
to 95 no injections.
And that's
deciduous teeth,
surface too? That's
any surface you want, regardless of depth. Sometimes even we encroach and get into the pulp and they still don't feel it. I would say adult teeth, closer to 60 or 65%. But still, you can do
60 to 65%.
No anesthetic. Occlusal class 2, class 3, MO, class 5s. If they weren't sensitive before on a class 5, then you can probably get the class 5 done with the laser without an injection. Can you promise that all the time? Absolutely not. And then it depends on your patient. Go into your geriatric patients, smaller pulps, things like that. You'll do 80% of the work without anesthetic. 100%, absolutely not. Because this is an all-tissue laser, you go soft tissue side, it's still going to generate heat, even though there's air, water, and laser energy coming out of the tip. You have to anesthetize or use one of the compounded super topicals that are out there to do what you have to do, and that's true with all of these lasers.
So look at my homie. Who should get this? Who does this fit?
So
which practice does this fit best?
I think, first of all, for a pediatric dentist, it's a no-brainer. I over the years, I've taught many pediatric dentists, and they've built their practice on laser technology. For the GP doing a variety of procedures, who's doing routine operative, some surgery, it's a no-brainer. Today we had a number of periodontists go out and buy the laser. They want to find a minimally invasive way to do a maximally invasive procedure. Lasers allow them to do that, so it fits them as well. You can make a case for almost anybody but an orthodontist to buy this type of laser in their practice, and they'll be happy with the results that they get.
So, pediatric dentists or your children would be the most freaked out by a shot. If mom doesn't like you, dad doesn't like you, but you do good with their kids, they're all coming to you. I mean, mom will throw the whole family under a bus if little Jimmy and Janie like you. So you think this is a no-brainer for pediatric dentists?
It's a no-brainer for pedo. They will build a practice. I have kids that specifically come to me for using the laser. Are you going to use a laser today, doc? And the only limitation really is removal of metal. So amalgam still presents a limitation. It'll remove composite and glass ionomer very, very quickly. But amalgam, if you have to remove an existing amalgam, you have to go back to shot and drill because it's not meant to remove metal.
Okay, so then a lot of people say, well, it's slower than a drill. But then other people say, well, yeah, but you don't have to wait for the anesthetic to soak on. So when you used to sit down and give a shot, then let it soak in, now you just sit down, pick up the laser, and start going. So for total time, what does the total time look like prepping with light touch, erbium, YAG laser versus numbing up, then using a high speed?
So my line always was in my lectures was, if you're going to anesthetize, and I have a case that I'm not, typically my patient will be almost walking out of the chair before your mandibular block took effect and really hits. It's really, your preparation is very, very quick. Your time is in the restoration, really, not in the preparation. It'll cut, if you want, as fast as a high speed. So you bring up an important point. What if a patient wants laser technology, but you have to numb them up? If I crank the power on the laser, I'll cut as fast as or faster than that of a high speed. We cut at low powers because it leads us very often to need to use local anesthetic. So it's still cutting quickly, but in that situation, if I were to erase a 557 in a laser, the 557 would win. But if I take the entire treatment, no anesthetic versus the block, well, we're going right at it. Right at the beginning, it's very, very rapid. Now take into account, what if the patient has multiple fillings in multiple quadrants? And I don't have to, and I can do an MO on 3, a DO on 31, an occlusal on 14, and a distal on 20, all in the same appointment if I don't have to anesthetize. Or an occlusal on T and a DO on K, all in the same appointment. Now you're much more productive. So it leads you to productivity as well instead of breaking up the appointments.
I want to ask you something very controversial. This is Dentistry Uncensored. We still have 5,000 pediatric dentists doing sealants all day, every day, while a lot of other people build up a body of research saying that 40% of these sealants have failed in a year, 80% have failed in 2 years, and there's a lot of people who believe that you should only do preventative resin restorations, which is an occlusal composite. True or false?
Did you know I lecture on sealants and caries detection? Did you know that?
No, I didn't. But I know Alan Miller says you're the smartest guy you can find.
So here's the trend. So today, I think that's always been a concern, obviously. There are a number of manufacturers that make clear sealant materials that will allow caries detection devices to fluoresce through the sealant. So, for instance, Air Techniques and Acteon have caries detection devices that use fluorescent technology. That you image the tooth, it'll show up on a screen and tell you if there's caries in a groove or not. Well, if you can take an image of the tooth and it tells you there's no caries in the groove and put a sealant over it, and then fluoresce through that sealant in 4 months, 6 months, a year or 2 years later, what value does that bring to your practice? Or if you can fluoresce initially and there's a little bit of caries in the distal part of the occlusal groove, and you just go ahead and do a minimally invasive restoration with a hard tissue laser with no anesthetic and seal the rest and can fluoresce through that 6, 9, and 12 months later, what value does that bring to the table? So it's all about education and the technology today, and I think that's where we're going. So Voco's got a clear sealant material that is transparent, that you could fluoresce right through the sealant, called Control Seal.
Okay, no, slow down. So Voco has a sealant. What's the name of it?
Control Seal.
Control Seal. And what do you mean fluoresce through?
So the Acteon's got a caries detection device that uses fluorescent technology. It's like an intraoral camera, but it has different LEDs in the head that allow you to take a digital image of the tooth, and that image appears up on a screen. If the image, if there's no decay there, the image will look like a green tooth with a bunch of grooves inside. If there is decay, well, then what happens, you will see in the grooves of the tooth, you will see different colors. Acteon has developed a proprietary scale that correlates with those colors. So red would mean early enamel decay. Blue would mean early enamel decay. Red, deep enamel decay. Orange would be deep dentinal decay, and yellow, early dentinal decay. Not exactly in millimeters, but it gives you an idea where the tooth is. So what if...
So you scan this, and it goes onto a separate monitor?
It goes right onto your monitor, and you can keep that
and
image.
It's called Acteon?
This is AirTech's device called Spectra. Spectra by Air Techniques.
Have they done an online CE course for this?
They've done some webinars, online CEO, I don't know.
Do you think you could get them to send me an hour-long
Absolutely.
digital
Absolutely.
course?
And Acteon's got a product, too, called Sopro Life that does something similar. It doesn't have the scale, but it also fluoresces onto the tooth. So I could save that image in my imaging software.
Yeah, there's my email, Howard at Dentaltown. There's
Got
my
it.
cell.
I will do that.
I wish you'd do that because I think all dentists agree that it's mostly about the kids. I mean, everybody would rather get an A in pediatric dentistry than in geriatric dentistry. I mean, why fix up grandpa when he's going to die next Thursday? But I'm really concerned about sealants and sealants failing, and I would love to learn more.
This is the way this technology is going. Acteon's product does the same thing without the scale. It's about getting that image, being able to see what you got pre-op, imaging through a sealant post-op, and being able to follow that image 6, 9, 12 months later. So just not to harp on this, but one little more point. Let's say you say to me, Ron, you know what? 40% or 60% of those sealants have decay, but it's early decay. What if I could take a remineralization cream like MI Paste from GC or Remin Pro from Voco with a brush, just paint it in those grooves, put a sealant over it, and see 9 months later if I could remineralize those grooves from the inside out.
I know, that's cool. I love both of those pastes.
It's possible. And that's where we're going to growing teeth. That's what this type of technology can really get to. So it's wild.
Who's the dentist product champions on those? Who could we talk to?
Talk to me. But if you
do it?
I do.
Why don't you build an online?
I can definitely do it.
Could you do that?
I'm a KOL for all these manufacturers, and I could definitely do that for you.
Well, I mean, I wish you would do that. I mean, we have there's 5,000 pediatric dentists in Dentaltown, and it is the most active part of our community. I mean, Dentaltown has on the app we have if you look right here, we have 202,000 members, and I think that was a minute ago, 2 minutes ago. They're talking around the clock, but we go to categories. We have a category called lasers.
I'm a big contributor.
Yeah, but the pediatric dentistry boards is one of the most active boards we have on dentistry. I would love to have an online CE course.
We could definitely do that because the technology about tooth growth and what's happening in remineralization protocols. We do a phenomenal. We have a phenomenal technique in treating white spots and getting white spots to look normal using a technique that we've come up with. A lot of fun things that we can do in that space.
Well, thanks for letting me go by and snag you at your booth. Congratulations on you guys squeezing the cost out of this thing, getting a product that's traditionally 75 to 85 to 115,000 down to 50. I mean, that's Alan Miller's legacy, is just squeezing cost out. That's so cool of a story that you got into this because of troubles in Crown and Bridge. And thank you all so much for what you do. And I would love to come back and get a course to really explain these sealants. But do you agree that most traditional sealants, as we do them now, are just failing and not working?
Absolutely, because there's just been no way to monitor. We can use dyes, we could do stuff. They're just too inaccurate. But these devices really can hone things down and really can make a sealant a much more predictable final result.
And if it was your daughter, how many old are your kids?
I got 20, 23, 21, and 19.
Okay, so mine are just little. My oldest 26, so yeah, maybe a granddaughter. So your granddaughter, when she gets her first year molars, her 6-year permanent molars, is it going to be a sealant or a preventative resin restoration?
It'll be visualization with a caries detection device, and it'll be a sealant for sure.
Really?
For sure.
See, mine is 3 years away. My little Taylor's only 3, but I always say when it's 6, I will actually clean out the grooves and do a preventative resin restoration. But you're saying we don't have to do that.
You just don't have, with those devices today, if you start using one, and you will see how accurate they are and how specific they are, I think you'll be blown away.
Well, that would be pretty damn cool if you put on an online C-course on Dental Town and change my view for your little niece.
Absolutely. Done.
All right, buddy.
Howard, thank you. Always a pleasure.
All right. Thank you so much for coming by.
You got it.